Good morning again. Welcome to the 2012 Everett v. Fox Student Case Competition Finals. We have Team Q with us. Just a reminder for those who have joined us in the room, if you can silence all of your communication devices. I'm going to allow some moments for the team to introduce themselves, and then we will start with our judges' introductions.
Good morning, everyone. We are Team Q. My name is Christina Lomax, and this is Jessica Johnson and Lavelton Thomas.
We'll have the judges start to introduce themselves.
Good morning, Jennifer Campbell Fitzgerald.
Denise Brooks Williams.
Good morning, Pam Sutton Wallace, Duke University Hospital.
Dale Oliver, HCA Healthcare.
Pastor Herb Buchanan.
Yvonne Spence, Dignity Health.
Good morning, Ken Page, Catholic Health Partners.
Okay.
Nice meeting you all. Good morning.
We just have a few reminders. The team will have 20 minutes for their presentation. Once you're ready to start, you'll indicate to the timekeeper who's sitting here over to your right, Phil. You'll receive a 5-minute warning prior to the end of the presentation time. Once you've completed your presentation, immediately following, we'll start the 10-minute question and answer session, and you'll receive a 2-minute warning from the timekeeper. And for our attendees, we just want to remind you that once the team has started their presentation, we won't have any movement in or out of the room until the full presentation has completed, including the question and answer session.
We're ready to begin.
Good morning, everyone, and thank you for joining us here today. My name is Jessica Johnson, and I'm joined by my colleagues Christina Lomax and Lavelton Thomas. We're a senior team with CLJ Consulting, and we're really excited today to present to you Mercy Plus, our innovative solution to coordinating the care for dual-eligible patients. Now, before I jump into our model, here's just a high-level overview of what a dual-eligible patient is like. As you can see, this is a very unique population with complex morbidities that are extremely expensive to care for. But to give you a better idea of what that care experience is typically like, I want you to meet Deborah. Now, Deborah's a 58-year-old dual-eligible patient living in Toledo, Ohio. She's been regularly visiting with her primary care provider here at Mercy, but he recently referred her out to an external behavioral specialist to help treat her depression. Now, this specialist had never treated Deborah before, and therefore did not have access to her updated health record. This led to him prescribing her a medication that adversely clashed with an existing prescription. Unfortunately, this led to a 4-day stay for Deborah at Mercy Hospital. And needless to say, she was not happy once discharged. Deborah began questioning the level and quality of care she had been provided. And she began questioning whether she could even afford quality health care. Now, as you can imagine, this level of fragmentation would be a detriment to any patient. But unfortunately, it's very common amongst dual eligibles when their care is not properly coordinated. But Mercy Plus will change all of this. And here's how we're going to do it. By establishing community-based partners, partnering with Aetna Health Plan, facilitating a multidisciplinary care approach, and integrating our health information systems, we will create Mercy Plus, an accountable care organization designed to care for the nearly 10,000 dual-eligible patients living in the Northwest Ohio region. Now, as a Mercy Plus enrollee, Deborah's health outlook is brighter than ever. Her primary care provider is able to update an electronic health record that'll be shared with all of her providers, even those external to Mercy, like the behavioral specialists. Now these providers are also regularly collaborating to ensure that that care plan is both consistent and continuous across the board. And now Deborah's a more engaged and informed patient. She'll have full access to her patient health record. She'll be able to collaborate with her providers as well. And she'll have the aid of a care coordinator that'll navigate her through her entire healthcare experience. So now that you've heard some of the great transformations Mercy Plus will bring about, I'm going to walk you through how and why to choose community partners, what that organizational structure will look like for the ACO Mercy Plus, and why we're recommending to partner with Aetna Health Plan. Now, most of you are aware of this, But as a high-level overview of why this is even possible, Ohio is participating in a demonstration project, and that's essentially looking to streamline both the payments and the care for these dual-eligible patients. Now, as a provider, Mercy is tasked with two things: figuring out which community providers they'd like to partner with, and deciding what that partnership really looks like, and then choosing a health plan that best fits the needs of that partnership. So we're first recommending that Mercy partner with community providers to form the accountable care organization Mercy Plus. And as you can see, we're recommending to partner with a broad scope of different organizations to ensure that all the needs of dual eligibles will be met with Mercy Plus. This includes the dual eligibles over 65 that are elderly and those under 65 that are mostly disabled. Now, as you can see, Mercy Plus is governed by the principles on the screen, but something I really want you guys to take home is that Mercy Plus is patient-centered and patient-driven. These are our primary stakeholders, and they'll sit on the advisory board to ensure that the execution of Mercy Plus best fits their needs. We're also recommending this organizational structure based on industry standards and best practices. So you have your chairman of the board, then you have your vice chair. We're recommending that this vice chair is a medical director to ensure that you have that clinical expertise at the helm. And then you have your subcommittees, and they're really tasked with, again, ensuring that Mercy Plus stay patient-centered and quality-driven, and to ensure that Mercy Plus is sustainable for Deborah and all the other patients you're going to treat. So now that the ACO is in place, we then recommend that you partner with Aetna Health Plan, and this is for several reasons. Aetna offers a variety of products and services that best complement Mercy Plus and what they're trying to accomplish as a patient-centered accountable care organization. Now, just to drill down into the four that you see highlighted, Aetna offers these great data reports. And what this does, it takes the claims data that most insurance companies already have, and it makes it useful. So they analyze this data, they put it in report form so that the administrators and clinicians of Mercy Plus can easily decipher it and turn it into improved health outcomes. Now, Christina is going to touch on the professional development and the home delivery of prescriptions, but the last thing I want to leave you with is the online patient health tools. And again, we want to reinforce the fact that we want our patients more engaged, more informed. Deborah and any other patient and their families will have access, again, to the full health record, and they'll get customized recommendations for care management, for medication management, and for referrals to physicians within their area. Now that you've heard all the great things that'll go into Mercy Plus, Christina's going to walk you through the operations and demonstrate how Mercy Plus is structured for success.
Thank you, Jessica. So now I'm going to discuss the coordinated care model that we expect Mercy Plus to employ. As you can see, it assumes a patient-centered approach, but what makes Mercy Plus particularly unique is the fact that it takes elements of pre-existing care models and puts them all into a coordinated model to provide health care across the continuum of the experience. There's also a care coordinator that is the glue that really holds this model together and helps the patient navigate each aspect of the care model. The care coordinator will conduct a consultation visit with the patient as well as their families where they will develop a personalized care plan for the patient based upon their needs as well as preferences. They will also discuss the dynamic services that Mercy Plus has to offer, including independent living skills training for the disabled population and the Mercy Plus buddy system for the elderly. Care coordinators will also be expected to maintain regular patient contact, but this will be dependent upon the patient's risk level, which I will discuss in the next slide. The care coordinator is also expected to help engage communication among the patient and the provider by helping to schedule the patient's appointments, as well as taking part in the referral process to ensure smooth transitions of care. Mercy Plus will provide funding for these care coordinators. However, it is up to the primary care provider to determine who will serve in this role. We also expect to use Mercy College to help develop a training program for these care coordinators, so that way they have a standardized approach despite the background of the care coordinator. So we've decided to tier the patients based upon their risk level, and as you can see, their risk is associated with cost. The top 20% of dual eligibles that are the riskiest patients account for 64% of Medicare and Medicaid costs. 30% of patients account for 26% of costs, 50% of patients only account for 10% of costs. With that, we realize that care coordinators need to have varying levels of interaction with these patients. So for the riskiest patients, we recommend that they have a weekly phone call with the patient as well as a monthly home visit to prevent any hospital stays. And that patient and care coordinator contact will decrease as the patient's risk level increases. So what does the care model actually look like? First, I'm going to talk about the integrated electronic system. And this is the foundation of our model as it really helps to improve the communication among all parties. One of the objectives is to reduce readmissions, and we can accomplish this through the Bosch Health Buddy system. It will be a part of the standard discharge protocol, and it will be programmed to each patient's unique metrics, and the care coordinator will be able to receive feedback on the provider end, so that way they can be able to intervene to prevent a readmission. We also want to be able to integrate the patient record and electronic information, and Epic Community Connect is the way to go. Since Catholic Health Partners is in the middle of rolling out Epic, this is the opportune time to use this tool and help to give each of the providers in Mercy Plus a standalone EMR for their dual-eligible patients. What do the medical services look like? Since their care is so complex, collaboration is key. In order to improve collaboration, we recommend developing multidisciplinary care teams. Care team members will include the patient's care coordinator, their primary care provider, their pharmacist, as well as any other specialist that the patient may see. They will convene on an as-needed basis in order to discuss any potential changes in the patient's care regimen. We also want to continue to engage the providers and give them professional development opportunities to continue their education. We want to be able to identify coordinated care champions within the Mercy Plus network, so we can do this through Catholic Health Partners Physician Leadership Academy. We also want the providers to have a better understanding of the needs of dual-eligible patients, and they can do this through the webinars and trainings that Aetna offers that focus on things such as cultural competency as well as patient safety. So let's take a look at some of the aspects of our model that focus directly on patients. First is medication management. In order to improve the adherence to the many medications that these patients are taking, we recommend giving each patient a medication dispenser that will be equipped with a timer so they know when to take what medication at what time. We also want to be able to enhance their access to their prescriptions, so we recommend using Aetna's prescription home delivery system. This will deliver their medications right to the patient's doorstep, and it'll give them a 3-month supply of their prescription as opposed to a 1-month supply. This will help to eliminate any barriers that they have to getting their prescription refilled, such as transportation. And that brings me to the final leg of our model, patient engagement services. Social health is normally an aspect that's overlooked with this population, so it's particularly important to keep them engaged in both their health care as well as the community. And we can do this by hosting social events with faith-based and community-based partners. We also want to decrease any transportation barriers that these patients may have. So we recommend contracting with a local transportation company so that way they can have access to their medical appointments as well as any non-medical engagements they may have, such as these social events or any regular errands they may have to run. So just to conclude this section, Mercy Plus really wants to focus on bringing care closer to the home and back into the community. As you can see from the map, Deborah's care team surrounds her home, and she has easy access to all of her medical resources and no longer has to resort to the Mercy Emergency Department. This isn't just representative of Deborah, though. It's representative of all dual eligibles in the Northwest region. So this model will help to improve the quality as well as patient satisfaction of the dual eligibles. Now, Lavelton will conclude the presentation with the implementation plan and financial analysis.
Thank you, Christina. So now you've heard about the care coordination model. I'm going to walk you through the implementation plan and the financial analysis. During the planning phase, we'll identify community partners, negotiate a contract with Aetna, and develop evaluation criteria for Mercy Plus. In year 1, we'll begin enrolling patients in the program, and by year 3, we'll be able to evaluate the successes and failures of Mercy Plus. If successful, we hope to expand Mercy Plus to other hospitals in the Catholic Health Partners market. One of the most important aspects of the planning phase is developing quality metrics. We recommend developing quality metrics around 4 distinct areas: patient engagement, patient satisfaction, hospital utilization, and chronic disease management. Each of these areas are important aspects of the care coordination model and should be required for providers to receive incentive payments through the program. It's equally important to recruit providers who can adhere to these high-quality standards. Currently, Mercy Plus sees approximately 2,415 dual-eligible patients through 67 primary care providers and 136 specialists. We expect Mercy Plus to enroll 5,000 patients in year 1 of the program, increasing to 6,000 patients by year 2 and 6,500 patients by year 3. We realize that this does not encompass the entire dual-eligible population in Northwest Ohio, but believe these projections are realistic based on the competitive nature of the market. In order to treat this number of patients, Mercy Plus will have to develop a network of 179 primary care providers and 366 specialists. So how will you recruit all of these providers? We recommend recruiting providers who are already patient-centered and interested in collaborative care. Recently, Catholic Health Partners has acquired a number of physician practices and employed a number of physician assistants and nurse practitioners. We recommend expanding this initiative to recruit providers into Mercy Plus. Additionally, we recommend emphasizing the ability to extend patient bases, attend professional development opportunities, and receive incentive payments through the program. After recruiting providers, it will be important to begin enrolling patients in Mercy Plus. We recommend reaching out to dual-eligible patients through direct mailings, including mailings that are in both Braille and large print for our disabled dual-eligible population. Additionally, we realize that many elderly dual-eligibles are taken care of by their adult children. We recommend reaching out to this population through community centers and faith-based organizations, as well as the Senior Emergency Department at St. Anne's Hospital. Lastly, we recommend developing a creative financial model with Aetna Health Plan, and we're recommending a risk-free shared savings approach. Under the risk-free shared savings approach, Aetna will receive the first 2% of savings based on the full capitated rate. After that point, Aetna and Mercy Plus will share in 50% of the additional savings. On the other hand, Aetna will be responsible for 100% of the losses through the program, making this a risk-free venture for Mercy Plus. We expect savings through the program to come from reduced hospital readmissions, reduced preventable hospital stays, and reduced long-term care utilization. We think that many of these savings will be the result of the activities of the care coordinator that Christina talked about earlier. So let's take a look at our 3-year operational budget and see how Mercy Plus will benefit from this risk-free approach. On the left side, you see the percent decrease or increase from the current model. Beside that, you see the decrease in dollar amount or increase in dollar amount for year 1 from the current model. In the middle, you see similar information for year 3, and on the right, similar information for year 3. In year 1, we expect Mercy Plus to save approximately $408 per member through reduced hospital inpatient stays and reduced long-term care utilization, coupled by increases in prescription drug costs through medication adherence and increasing in physician services through preventive care. In years 2 and 3, we expect this trend to continue, with Mercy Plus saving a little over $1,200 in year 2 and a little over $1,500 in year 3. So let's see how your per-member savings will be affected by the number of members enrolled in Mercy Plus. In year 1, we expect 5,000 members to enroll in Mercy Plus, giving us a gross savings of a little over $2 million. From this, we must subtract initial investment in IT infrastructure and home-based health devices, as well as program expenses from care coordinator fees, corporation fees, training costs, and marketing costs, giving us a net loss in year 1 of approximately $717,000. Under the risk-free shared savings approach, Aetna will be responsible for this full net loss. In year 2 of the program, we expect enrollment to increase to 6,000 patients, giving us a net savings of $5.6 million. Aetna will receive the first 2% of these savings and 50% of any additional savings, giving Aetna a net savings of $4.9 million and Mercy Plus a net savings of $700,000 in year 2. In year 3, we expect enrollment to increase to 6,500 patients, giving us a net savings of $8.5 million, of which Aetna will receive $6.5 million and Mercy Plus will receive a little over $2 million. In the competitive Northwest Ohio market, we realize that enrollment in the program may not reach our projected figures. But even with a 50% decrease in enrollment, we still expect Mercy Plus to have savings in year 3 of the program. Likewise, with a 50% increase in enrollment, which would give us the full dual-eligible population in Northwest Ohio, we expect Mercy Plus to save even more. In closing, by establishing community partnerships, forming a partnership with Aetna Health Plan, facilitating a multidisciplinary care approach, and integrating electronic health systems, Mercy Plus will provide a solution to fragmented care for Deborah and thousands of other dual eligibles like her. Thank you so much for your time. Are there any questions?
Yeah, a quick question. Why'd you choose Aetna as opposed to the other?
Absolutely. So again, we're recommending Mercy partner with community providers to form an accountable care organization. And for an accountable care organization to be successful, there are certain tools that we would need from our insurance company. And that includes an integrated health, robust integrated technology system. Buckeye does not have the technological infrastructure needed to make Mercy Plus as successful as we anticipate it will be with Aetna. In addition to that, there is, based on our research, there's one county in the Northwest Ohio region that is a part of the ICDS that Buckeye does not currently cover. And this is straight from Buckeye's website. Ottawa County is a county that we are tasked to treating, and it is our obligation to ensure that the health plan we choose. Now, that is not to say that if Buckeye do advance their technologies, that is not to say that we won't expand with them as well. But as of right now, being that this is the first time we're doing Mercy Plus, it would behoove us and it's advantageous for us to select a health plan that already has the tools needed to set Mercy Plus and Mercy Health System up for success.
Based on the financial model, it looks like Aetna would actually be funding the initial startup. That first-year loss would be absorbed by Aetna. So is that a challenge from your perspective, or why do you think that will work with them?
So we believe that both Aetna and Mercy Plus will be engaged in this venture. Both of them want to save money through the program. Currently, Aetna already has all the risks of the dual eligible populations. If claims are high in 1 year, Aetna will be responsible for paying those claims. If claims are lower, Aetna will receive all of the costs. We believe that by creating an ACO and partnering with Aetna, both parties have an incentive to save money through the program. So we think that Aetna will be responsible for this savings, or will be responsible for this cost in year 1 because they already have all the risks through the program. And now, Mercy Plus will have an incentive to save money and hopefully save Aetna money in the future. And no good program, of course, can be created without upfront cost.
So you did a nice job of summarizing the impact of the changes. Could you just briefly tell us how you calculated the changes, acute care, prescription? How did you calculate the impact to create the savings?
Sure. So we used a couple of different articles to calculate the savings. First of all, we found the capitated rate using the Kaiser Family Foundation website, as well as the Mathematica article that it talked with the Medication and Medicare Coordination Plan Office. So we found the capitated rate. And then from that number, we used a CMS primary care initiative that talked about the impact of care coordinators in the primary care environment. And we looked at the impact over a 3-year period, got those 3-year numbers, and then estimated the cost over the 3 years to get to that 3-year period number.
Thank you.
Can you describe a little bit your staffing model for the care coordinators as well as the primary care, sufficient capacity for primary care?
Absolutely. So we expect the staffing for the care coordinators. We expect that each care coordinator will have approximately 30 to 40 patients, and this will result in about 217 care coordinators by the end of year 3 if they're each taking on 30 patients. Additionally, for the primary care providers, we also expect, as Levelton said, 166 primary care providers to be engaged in Mercy Plus. We understand that they will also have other patients to care for that aren't just dual eligibles, so that's why we have that number. And we also expect that 2/3 of those primary care providers will be either nurse practitioners or physician's assistants.
Great, thank you.
Can you explain the medication dispensary that you have? Is it going to be paid by Mercy Plus? And then also, can you talk about the buddy system? And how that's gonna
Absolutely.
work?
So the medication dispenser, it will have a timer, and the patients will be able to insert their medications on certain days at certain times. The timer will go off, and so they know when to take what medication at what time. With the buddy system, it will be paid for by Mercy Plus. It's a part of the upfront costs that we have included. And then as far as the buddy system goes, we will be engaging community volunteers. Either likely they will be younger, and they can write their senior buddies if the dual eligible enrollees decide to opt into this program, if they don't have a family or things like that, just to give them accompaniment and improve their social morale.
And you also talked about at-home, Aetna's at-home dispensary or delivery of the medication. So
Right.
you're expecting the patients to fill their medication boxes?
So with the care coordinator is going to have constant contact with the patient. And we expect the care coordinator to work with the patient, and as well as the multidisciplinary care team, which will include a pharmacist, to make sure those medications are filled correctly. So we don't expect the patient to do this, but through regular PCP visits with their primary care provider, as well as regular communication with their care coordinator, we'll make sure these medications don't adversely affect the patient.
Can you speak to what your patient incentive thoughts are? What will help patients to be incentivized to be a part of the plan?
Absolutely. So first off, the way this plan is rolled out, all dual eligible patients will eventually have to enroll in a health plan like this. As far as what makes Mercy Plus different is that we're taking the best of the best products and services, not just from what Mercy Health System currently offers, but from any community provider, and we're putting it in one place with the Accountable Care Organization. And as we all know, accountable care organizations are very new. It's new territory for everyone, but it is our hope that the way we're staggering our planning and the way we're implementing it is that it'll ease patients into this new experience, because there is a chance that many patients won't really be familiar with the ICDS plan. And so the way that we have it structured and the educational tools we provide make it the easiest for them to assimilate into this plan. And I think our support services will help us stand out from any other ICDS plan that may develop in this Northwest region. So it's really that personal touch. It's the contact that we'll be able to provide to them.
You mentioned the technology, information technology and electronic medical record, and obviously Mercy has the Epic system, but not all the stakeholders will be linked in with Epic, so could you
Right.
speak to that issue?
So that they will be able to do that through Epic Community Connect, which is a tool that Epic offers. So that way, each of the providers within Mercy Plus will have a standalone EMR. They will have to pay a subscription fee to get the standalone EMR, but it will help to improve their care coordination, so they will be able to see what the primary care provider at Mercy was able to do if they're at a specialist site.
Right. And
Is that cost covered under your financial plan, or would that be this various entities needing to pay that
so,
fee?
as you know, Epic is very expensive to implement. So the subscription fee is going to be worlds cheaper than potentially investing upwards of $200 million to get Epic for our community providers. So for them, they are incentivized to just get the Community Connect connection versus having to implement an entire system. So that fee will be covered by our individual providers. That's not a Mercy Plus expense. But again, the benefits far outweigh that subscription fee in the grand scheme of implementing an electronic medical record.
So Deborah is a member of my congregation, and iPhones and Androids scare her to death. How are you going to help her with that technology use?
Well, the care coordinator will have other resources, so if she is not a fan of the technological infrastructure that Mercy Plus has, she will engage in traditional education. The care coordinator can come to her home and educate her just face-to-face, give her notes and handouts and pamphlets if she is not a fan of, the technological applications that Mercy Plus has to offer. We try to ensure that we understand that half the dual eligible population is elderly and they may be adverse to technology, so we have that infrastructure in place.
We have some print materials like an aftercare plan. So when a Mercy Plus patient goes to their provider, the multidisciplinary care team creates an aftercare plan, which is a printout, and gives it to the Mercy Plus enrollee. In addition, the care coordinator will highlight social events as well as appointments on a paper calendar for our Mercy Plus patients, so that patients that don't have technology or aren't used to technology can still use that. We also realize that many Mercy Plus patients are taken care of by their family members. So even if elderly Deborah doesn't use these patient tools, her adult children or her grandchildren will be able to use these tools to take better care of her. So we still think they're a benefit for the program.